Are we counting down, Reed? I don't see the countdown. Oh, yeah, there we go. Live. Oh, we're live. Awesome. Look at that. Hey, everybody. I'm delighted to welcome Stephanie Winn for conversations with me, Peter Boghossian. Stephanie is a licensed marriage and family therapist with a private counseling practice in Oregon. She's the host of the podcast, You Must Be Some Kind of Therapist, and she's featured in the excellent documentary, highest recommendation, No Way Back, The Gender Reality of Affirming Care. Last year, Stephanie was investigated by the Oregon Board of Licensed Professional Counselors and Therapists. I'll give you my opinion about those individuals later. And she has been accused of practicing, quote, conversion therapy, unquote. Hey, thanks for joining me today, Stephanie. I appreciate it.
Thanks, Peter. It's great to be here and finally meet you.
Oh, excellent. So let's jump right into it. So you have a private counseling practice called Real Talk Therapy. And according to your website, you offer therapy without ideology. What ideology are you talking about? And what's captured the mental health field and how widespread is it?
It's interesting that you ask about that. I don't know if you saw the recent Wall Street Journal op-ed published by my colleague, Dr. Andrew Hartz in New York from the Open Therapy Institute. But there are a growing number of people of all walks of life in the counseling profession who are expressing a great deal of concern about the politicization of our field. I've, on my podcast, interviewed therapists who were recently in grad school and where the sort of current ethos in grad school and training programs is that therapists should not be culturally competent in working with conservatives. And I say this as somebody myself who is not politically conservative. I'm somewhere between moderate and homeless. But there's a great deal of, for lack of a better word, wokeness taking over our field. And I mean, as you are well aware, I've been following your work for years, as well as the work of James Lindsay and why is his name escaping me? Jonathan Haidt. He's one of my favorites, right?
Oh, yeah.
Some of the ideology that's captured our field is really antithetical to the principles of good mental health.
So the ideology, I'll just tell you a quick story. A friend of mine told me this. I won't mention the name of the university. I will say that it's a large urban school in the Pacific Northwest. And a public university, this individual is telling me in the psychology program to become a practicing psychologist. On day one, the thing they teach you when you deal with homeless people is not how to find a job or hygiene or how to get clean or any of that stuff, mental health counseling. It's pronouns. Like, that's the first thing that they talk to people about. And so I mean, I can give you anecdotes of systemic derangement, but what can you tell us? Like, how does that ideology matriculate, or how does that flow through the institutions? Like, is it woke professors assign woke reading? Like, how does that mechanism work?
Well, clearly we don't have our priorities straight. And your statement about homeless people being asked about their pronouns reminds me of many things I've seen in the counseling field where, I remember times that I wished that Child Protective Services would do something about a situation, but it had to reach this level of abuse and neglect for CPS to act on it. And yet CPS is getting involved in perfectly safe families because they refuse to use their child's preferred pronouns, right? It's like we're not getting our priorities straight. So how is this happening in the institutions? Well,
you could hold on 1 second. I'm sorry. So I just want to ask you about that because I know people will be curious. I'm sorry to interrupt. So I just want to make sure that I understand.
Sure.
So that Child Protective Services are getting involved when parents refuse to use the pronoun that they're like, if it's a born a natal boy and they want to go by Zer or what have you. If parents don't use that, we know that there are documented cases in Oregon where CPS has been involved.
Yes, and there are cases where a child has been hospitalized for suicidal ideation and held in the hospital much longer than they normally would. I know this because I've been in the field 10 years, and my first few jobs in the field were more high acuity populations. So my first few jobs, my patients were frequently hospitalized or Child Protective Services were involved. So I've seen the trends and expectations and sort of the standard of care. And I know what level of acuity someone typically has to be at to be kept in a hospital when there is the option of being safe at home with their family and the family being offered counseling as to how to safety plan appropriately at home. So I've seen situations in which the family was perfectly capable of keeping a youth with passive, not active suicidal ideation, no plan, no access to anything that they could harm themselves with, but they kept them in the hospital and made the whole issue about affirmation, about
So, yeah. So tell me. So let's drill down on that because I find that fascinating. So, what does that mean? Affirmation, and what does it mean? What is like the reality of gender affirming care? Like, let's disambiguate. Let's talk about that word affirmation. What do they mean by that?
well, so they mean agreeing with, endorsing the self concept that a young, vulnerable person, typically who's spending a lot of time online, tells you about themselves. Agreeing with it wholeheartedly, and in many cases, lying to your child about how you truly see them and how you feel about them. Agreeing that the name you lovingly gave them as a parent is now their dead name. Agreeing that the daughter you raised since she was in diapers is now your son. So parents are being pressured to quote unquote affirm this.
Okay, so I'm going to show you a clip. I would like to try to be as neutral as possible on this stuff, but it's just so demented that it's very difficult for me to maintain the veneer of neutrality. But we're going to show you a clip. Reed, let's take a look at that clip about gender
affirmation refers to the process of reflection, acceptance, and for some, intervention. Basically, the idea is to accept the person for who they are. So, what is the typical course for a young person who seeks gender affirmative care? Well, first it starts with social affirmation. Now, this includes adopting gender affirming hairstyles and clothing.
Pause. Okay, what do you think of that so far? We're going to watch this, and I want to get your feedback on this.
Oh, you paused it early. I love.
Oh, you want us to keep going?
Well, but I started taking notes already because the first thing I noticed is that he's admitting that first it starts with social affirmation. That is the reality, right? Social affirmation actually increases the likelihood of the persistence of gender dysphoria. So let's just stop and break that down for a moment. Gender dysphoria is a mental disorder as it currently stands in the DSM-5. And there's no other mental disorder in the DSM-5 that we treat with surgery. I mean, the last time we treated a mental disorder with surgery was lobotomy, right? Or maybe you could make a case for binge eating disorder being treated with a gastric bypass. I don't know. I see. Sorry. Just looking at the comments. Sorry. Let me just catch my train of thought. So, sorry, I just lost track and I'm getting back there.
I interrupted you. I'm terrible at that. I'm sorry.
So the thing is that mental disorders are treatable, and many will go away naturally with time. Many people will experience relief from distress with the non-invasive intervention of counseling alone. So in order for something to be classified as a mental disorder, there has to be clinically significant distress or functional impairment, meaning that person is either having difficulty at work, home, school, in important relationships, difficulty taking care of their health, or when we say clinically significant distress, that means, distress bad enough to see a therapist about it. So there has to be some kind of distress, right? And so our goal should be to alleviate that distress in the most non-invasive way possible. There is a naturally pretty high desistance rate. People who experience gender dysphoria in youth, 80+% of the time, will no longer experience it as adults, right? However, the social affirmation piece, to bring it back to that, increases the persistence rates of the disorder. So with any other form of psychiatric distress, if there was something where we knew that a certain behavior increased the likelihood that you would continue to suffer that form of distress for longer, then the standard medical advice would be to avoid that behavior and maybe counsel the people in the person's life about how to help them avoid that behavior. But instead, what they're doing is they're recommending the very thing that's going to make the distress persist. So in other words, they're reinforcing the thoughts around, I'm really a boy trapped in a girl's girl's body or something like that, which then creates what I think is very akin to sort of an obsessive compulsive pattern of thoughts and behaviors regarding the fixation on the idea of gender identity, the fixation on the body dysmorphia, the distress, and the idea that these medical interventions, which he's about to say are the next step, are going to alleviate it. So he's basically admitting that that's how it works. At the same time, gender activists will often pressure people into this idea that just affirm, just call them the name and pronouns that they want, and then they'll be happy, right? Which we know maybe they're elated for a week if their parents give in, but then they're asking for the next step.
Okay, so you used a specific word. Well, many specific words. I have two questions for you. So, unfortunately, as you probably know, the people who advocate this are not merely allergic to any form of conversation or discourse or dialogue, but they are overtly hostile to it. So we can't get anybody to talk to me about this. So we're going to have to look at clips of what people say with nobody responding and have you respond. I think I love the phrase Judith Butler calls that non-consensual co-platforming. So we're non-consensually going to co-platform. Okay, Reed, I want to take a look at the word disorder. Can you pull up that video? Because that's a very specific thing. And while Reed pulls that up, I'll tell you the next question that was on my mind. The idea that because I think I'm fairly confident that this is what they'll say. The DSM is just a book of social constructs. It's by white people to preserve their own privilege. There's no objectivity to it. It's all bound up in power dynamics. Okay, so let's look at this guy who clearly.
Oh, do I get to respond to what you just said, though?
Yeah, go ahead, and then we'll take a look at disorder.
I agree with about half of that, right? I don't think the DSM is very objective. It's certainly been changed many times. It's highly debated. I don't think we need to bring race into it, though. But
homosexuality.
But they have no problem exploiting how the system works to push for the so-called gender affirming care. They have no problem using medical terminology. And the thing is, they want so-called medical treatments for something that they're also saying is not a medical disorder. They want to say that it's not a medical disorder, it's not a mental health disorder, we shouldn't pathologize it, it's perfectly normal. But at the same time, in order to have a medication, a surgery, or any kind of intervention in our current medical system, there has to be a diagnosis. So they're perfectly willing to exploit the system and change the narrative depending on the situation.
Yeah, that's an excellent point, and it gets back to what you said before. And I think that the key is that this idea that it's a disorder. So, so I want to talk to a second about how we adjudicate whether or not it's a disorder. But let's listen to and read. Do you remember what's this guy's name again? Do we know his name?
I don't know, but I love that the book in the background says "Playing God" because that's exactly what they're doing. It's like they're admitting it right there on the screen.
Yeah, it's great, isn't it? It's great. I think he wanted another. I think he had another use for that. But all right, let's play. We'll put the comments. We'll put his information in the YouTube comments.
According to the American Psychiatric Association, being transgender or gender variant implies no impairment in judgment, stability, reliability, or general social or vocational capabilities. However, these individuals often experience discrimination due to a lack of civil rights protections for their gender identity or expression. Such discrimination and lack of equal civil rights is damaging to the mental health of transgender and gender variant individuals. So, mental health issues among transgender people are more the effect of multiple factors, including discrimination, instead of an underlying difference in the amount of mental illness compared to the cisgendered community. If a mental health issue exists, it most often stems from stigma and negative experiences rather than being intrinsic to the child.
Can we pause?
So transgender people aren't born with...
Go for it.
Whew. That is a really appealing narrative if you are ashamed of yourself, if you have a trauma history you're trying to run from, if you experience some kind of rejection or bullying. Almost half of these kids presenting to these clinics are autistic.
Yeah.
So they feel very socially awkward because they are socially awkward. They've been disliked and they don't know why because they can't read social cues very well. there are all kinds of reasons that a person could have all kinds of issues going on with their mental health, and that this would be a really appealing narrative. It's not my fault. Everything would just be better if everyone would just affirm me and give me what I want, and the reason for my problems is discrimination. Now, there might be some truth in some of that, in the sense that many of these individuals, in fact, have faced some kind of trauma, abuse, bullying, or things like that. But to generalize it, right, to make it about society. It's about society not accepting me, or it's about my parents not accepting me for being trans, rather than whatever the real issue is going on in this family conflict, which might be intergenerational. It's a very appealing narrative. And it's also a dangerous one, because it sets up a whole, there's a lot downstream of that, right? Because if we assume that what he's saying is true, and that the reason that we have such high rates of all kinds of psychiatric comorbidities amongst trans-identified people is due to discrimination and stigma, then what does that mean? It means in order to save this poor marginalized community, we have to reorganize society, we have to fight against the bad people like you and me, who are contributing to the oppression and stigma, and we have to make sure everyone knows how wonderful it is to be gender variant, which then means we're creating a culture that continues to send the message to vulnerable young people that if you're feeling shy, awkward, embarrassed, if you're having anxiety adjusting to adolescence or anything else going on in life, all you have to do is identify as trans, and you'll have a whole bunch of people supporting you and fighting discrimination on your behalf. And then you don't get to find out for years. You don't get to find out until you've gone all the way down that path, and you've modified your whole body and your whole life and your whole future and identity, and you've spent crucial developmental years cultivating that maybe actually that wasn't what you needed to do to alleviate your distress.
Okay. So I have as my friend Michael Schellenberger says, there's just so much crazy here. I mean, I could have this conversation for literally hours and hours. Okay. So I'm trying to not steel man this, but I'm trying to get it in someone's words who, like John Stuart Mill says, like somebody who's a believer. I'm trying to get it from a believer so we can look at that, as opposed to me trying to say what people believe when I don't believe it. So Reed, let's keep going with the clip, please.
They also start using gender-affirming name and accurate pronouns, and they begin using non-binary restrooms or gender-identifying restrooms. So the first part of this really is just lifestyle-based. Now the next step is puberty blockers, and I know that this is a bit of a controversial subject.
Yeah, thanks.
So let's explain what this is. Gonadotropin-releasing hormones have been used since the 1980s to prevent puberty in children who have central precocious puberty. Basically, by giving these hormones, you can slow down that pubertal process and prevent it from happening. Now, they can be used in adolescence until the age of 16 to give the child and the parents and the healthcare professionals time to explore their gender identity, to develop coping skills, and to give mental health support and really overall support the family, and of course define the goals of their treatment.
Pause. All right, you're cringing there. I know. There's so much here. I acknowledge. Go ahead. Go for it.
I mean, where to begin? So first of all, GnRH agonists, I believe, have been used since the 80s. Yes, with bad results. People who took Lupron in a way that is arguably much more necessary, medically necessary, and Lupron being the biggest name brand GnRH agonist, have major problems with bone density that are well known. I believe there have been lawsuits about this already. So and so that's in a case where there is central precocious puberty, where a kid is maturing way too rapidly, and there are other medical consequences downstream of that. So there's a case to be made for slowing puberty down so that the rest of their body can grow in the stages before that, and so that they're not embarrassed by developing before their peers. So there are definitely known problems with administering this, even when medically necessary. Then he's saying you can just go ahead and give this as that the pause button, the time to think, right? As that recent book that came out exposing what happened at the Tavistock, which I love that title. So this is the myth, right? That puberty blockers give time to think. as if you can just slow it down or pause life. And that's a myth for a number of reasons. So one is that puberty, there's a lot happening during puberty, including crucial phases of skeletal development. This is why our biggest concern of all about administering puberty blockers to children is lifelong problems with bone density that can create osteoporosis and osteopenia. Now, I'm going to venture out onto a limb and connect this to another important issue when it comes to the trans debate, which is the myths around suicide. Because if you actually look at what we know about suicide, one of the factors that places people at higher lifelong risk of suicide is chronic illness and disability, right? It is hard to spend years of your life unable to exercise, so unable to do things that are fun, unable to socialize, unable to do things that generate feel-good chemicals in your body. And there are many negative consequences downstream of that. So they're essentially arguing that children who are otherwise on a physically healthy developmental path should be put on drugs that will impair their bone development and put them at risk of osteoporosis, osteopenia, bone fractures, and basically potentially being disabled. Now, if you're interested in the lifelong suicide risk of an individual, you should definitely be concerned about those factors. What to speak of the brain capacity? I mean, they're talking about interfering with your pituitary gland and
right? Yeah.
Administering puberty blockers to children. First of all, there's all kinds of risks of brain swelling, blindness even is a risk. And the idea that giving kids something that stops their hormonal development and their brain functioning is going to help them think more clearly is utterly backwards. We know that the treatment for many of these kids is to actually go through puberty. Why? Because of that natural desistance rate. If you go through time, you grapple with the rocky ups and downs of puberty, eventually come to terms with your sexuality, you can make it to adulthood and be okay.
I'm very rarely do I become overwhelmed with all the rabbit holes we could go down, but the trans issue is there's just so much stuff we could go down. But again, I really want to try to be fair and play his comments and have you. I think that's the best method to be fair. And by the way, I'd like to invite this guy, Dr. Huan, on to have a conversation with me, or I'll have a conversation. He won't come on. There's just no way. These people simply refuse to talk to you. But I'm putting the opportunity out there, and now watch, I'll get like 10,000 people who want to come on who are not qualified to talk about it. If this individual wants to come on, I'm more than happy to have a conversation with him, or broker a conversation with someone who's an expert in this. All right, Reed, let's keep going.
If these puberty blockers are halted, then they progress naturally into puberty. Well, studies show that providing puberty blockers to adolescents who identify as transgender generally...
Just a clarification, he says if the puberty blockers are halted, they will progress naturally into puberty. While there will be some further development, there is a risk that the puberty blockers have permanently interfered with things like penis size, breast size, and things like that.
Yeah, it's funny that you picked up that. I picked up something totally different from that. I picked up that what studies, what journals, who are the qualifications of the people, what are the methodologies of the studies, how many studies, have they been idea laundered? That's what I got from that. So I would have liked to know. I can't, maybe it's a pet peeve of mine when someone says, well, there are studies. Well, what studies? What are the names of the studies? Who did this? Who conducted the study? What were the expertise of the people, and what were the journal? What were the impact factor of the journal? Like, not that it tells you something. I mean, it doesn't tell you everything, but it's interesting. We picked up different things.
And in our film, we show studies that 95% of children put on puberty blockers do go on to cross-sex hormones. So puberty blockers increase the likelihood that children will continue down this path.
So they're a gateway.
Absolutely.
Okay. All right, Reed, keep going here.
Generally leads to improved psychological functioning in the young adulthood. And really the goal is to prevent their natal gender physical pubertal changes from happening. So if somebody is a transgender girl and they're starting to go through puberty...
I'm sorry, I would also like to
know
what evidence he's talking about when he says that that their overall psychological functioning is improved after this, because as far as I'm aware, there are studies that showing that people who have had trans-related hormones and surgeries are on more psychiatric medications.
Do you know
afterward.
that? So I'll hold you to the same standard. Do you know the names of the studies? You happen to have any
Not
of
off
those?
the top of my head. I could go digging for it.
Afterward, you dig, and we'll put it in the YouTube section. So in case anybody says that, I have some kind of axe to grind, that they can look at the data
Help me out.
themselves.
Send me a reminder email.
Okay,
I would hope it would be on Stats for Gender. That's where I usually refer people. And anyone can leave that in the comments too, because other people are probably hearing that study and it's ringing a bell. The one that showed that people are on more psych meds after.
Yeah, and if anybody wants to cite the studies that he's talking about, sure. So put those in the comments, and I'm more than happy to take a look. I have no medical expertise. I have to say that 1,000 times. So I'd be just looking at this from.
But you know what I think he might be citing though? He might be actually misinterpreting these bizarre have you heard of like the chest dysphoria rating scale?
Yes.
Right. So they take something like the chest dysphoria rating scale, which is basically, a female before and after having a mastectomy, specifically rating her feelings about her chest, but it's in like a 3 to 6 month window after the surgery, which is really not enough time.
Right. It has to be longitudinal, and it has to be, because you'd have a precipitous drop off rate if they weren't happy, so they wouldn't go to the same facility. So, all right, let's keep going with that video. And again, I'd like to invite Dr. Winn. Oh, I'm sorry if I'm mispronouncing your name, to come on and have a conversation. Go ahead, Reed.
Trying to go through puberty, we don't want, let's say, the Adam's apple to enlarge. We don't want the facial changes to occur to make this transgender girl to develop more as a boy or a man. And this is because these can necessitate surgery to reverse, and obviously as a surgeon we know we don't want to perform surgery that we don't have to. Now the next step is cross-sex hormone therapy.
Pause. I mean, you can say that about the whole thing, right?
Yeah, we don't want to perform surgery that we don't have to. None of this is necessary.
Right. And the claim that it is necessary is because if they don't get it, and you address this, and he addresses this later in the clip, is that suicidal ideation, or they're far more likely to kill themselves. Colin Wright has some good data on that hasn't been borne out. All right, Reed, keep going.
Starts in early adolescence. So testosterone is given for female to male transgender patients, and estrogen plus androgen inhibitors are given for male to female transgender patients. And these medications give the transgender person the physical characteristics of their true gender identity. So if somebody's going
pause. I'm going to start doing your thing. I like that. True gender identity. So that means what? That there's an objective matter of fact about the world. And so I guess that he would want to ground that in subjective experiences as opposed to any objective test that we could do, a kind of a cognitive. I mean, I would love to figure out what he means by that. What are you thinking?
Yeah, I think it's this the supremacy of the subjective over the objective, right? The idea that identity is something you know about yourself, and that what you know about yourself, whatever you feel, is more important than how others see you or what the material reality of it is. And that there's this something so fixed. I mean, it's funny because these are the same people who will say that you can be gender queer, gender fluid, you can be non-binary, your gender identity can change from one day to the. I mean, they will say that, right? So on the one hand, they're arguing that it's malleable. On the other hand, they're saying that you have a true gender identity that only you can know, and you should really modify your body, and then you'll be happy forever.
Yeah, I mean, how much can you really know about yourself at 12? I mean,
this is something I ask people all the time. Like, when you think back to when you were 12 or 17 or even 21, how much of what you thought you knew about yourself, or what you wanted for your future, or what you wanted in your relationships, how much of that holds any merit today?
God, it's just so insane. This whole thing is so crazy that the fact that we would have to sit here talking about this is just okay. Reed, keep going.
Male to female, being on estrogen plus androgen inhibitor hormones would, let's say, give the person a higher voice, maybe softer features, and other traditionally female characteristics. For female to male, testosterone will make the voice deeper, it will give more facial hair, and give the figure more like a traditional male figure. Now, the last step in transitioning is gender-affirming surgeries. Now, the data is very clear that undergoing gender-affirming procedures, including surgery, is very beneficial for people with gender dysphoria. Now, there was a...
Is the data clear on that?
Oh, I don't know of any evidence to that. I know that the suicide rate in this population is highest 7 to 10 years after surgery, and anecdotally at least, and there might be some data on this as well. It seems like in the detrans community, basically, the more a person is done to alter their body, the worse their mental health is down the line, and the higher they are at risk of suicide. That's what I've observed.
Yeah. So you get that observation from your clinical practice? Is that?
Yeah. I've heard that from detransitioners.
Yeah. So Reed, I would love to know. So if anybody in the comments knows where what I don't know, about maybe 10 or 15%, I'm just plucking that out of the air, but I think it's roughly accurate, of the people who watch these videos utterly despise me. And so if any of the people who despise me want to, please put in the comment and I will read the study. All right, keep going here.
Now, there was a survey of over 22,000 transgender people, and they found that gender-affirming surgeries were associated with a 42% reduction in psychological distress.
Okay, now why would you do that? Like, no, I'm like totally, why would you just throw out a number? There was a study and not say why would you do that? Why wouldn't you just say, oh, there was a study in the New England Journal of Medicine in March 2004 that said this. And so you could go, this. I don't know if that's just lazy or he doesn't want to complicate things, but I don't know. That just seems not just sloppy. It seems, I don't know. All right, keep going, Reed, keep going.
Well, and there's also a huge placebo component to here, right? The power of belief here, if especially these young people, they've been chomping at the bit, the impulsivity of adolescence, and you think you want this thing right now, and 6 months feels like forever. And so if you're 13, 14, 15-year-old kid and you've been begging your parents for a double mastectomy and they finally cave in, then of course in the aftermath of that, you're going to be like, I got what I wanted, right? And that's going to last a little while before you start to really deal with the long-term impacts.
Yeah, you'd need longitudinal studies, but you'd also need venues. Like the only one I could think of off the top of my head, and it's probably not the best one, is Journal of Controversial Ideas, but that's Peter Singer's journal out of Australia, the Australian ethicist. But you'd need some journal that wasn't held to the morally fashionable, that looked at evidence-based. I was just at a conference and there was a fascinating guy there. I can't remember his last name, Bernie. And he, and again, I don't know, COVID rabbit hole and yet another rabbit hole we could go down. But he was talking about how publications in certain domains, they don't even look at them within the field of medicine. So my concern would be, and again, Colin Wright has talked about this, and his wife, what's her name? Christina Buttons Reed, is that her name? Other people have talked about this, the difficulty of getting that published. But neither here nor there. Play the clip because that's subsequent to this is super interesting.
44% reduction in suicidal ideation when compared with transgender and gender diverse people who had not had gender affirming surgery, but they wanted it. One study found 56% of youth who identify as transgender have contemplated suicide, with 31% actually attempting suicide. Now, this is compared to cisgendered, which is 20% and 11% comparatively.
Reed, why on earth would anybody think that that's causal? My buddy Eric Weinstein said to me at lunch a while ago, you don't really need, the only thing anybody really needs to go to undergraduate for is learn the difference between causation and correlation. Everybody knows that anyway, so what's the point of it? But that's basically what he said, paraphrasing. This guy, I mean, where's the evidence that this is causal? It could be that there are these underlying health conditions or pathologies, and they manifest themselves in this one kind of, I don't know, suicidal ideation or what have you. I mean, what not only where is the evidence, but what would that evidence look like? Like, what would an independent person who's looking at the data, what would cause a light bulb to go off and like, wow, okay, there it is. I would love to have that conversation with someone.
Seriously, this point cannot be emphasized enough. We all agree, on those of us on all sides of the issue agree, yes, this population is in distress and they are
Totally.
at higher risk of suicide. Absolutely. It's just we disagree about the causation. And I just like to point out what a reckless and dangerous assumption it is, the way that they're thinking about mental health, right? So, and this is the opposite of what we reveal in our film, right? In No Way Back, we show that there are all of these underlying issues: sexual trauma, abuse, neglect. We know that people who have been in foster care or adopted or have otherwise attachment disorders are more represented in this population. So are people who are autistic, so are people who are same-sex attracted, right? There are a lot of underlying issues going on here. And in my mind, it's very appealing to latch on to an idea that, as we were talking about earlier, it's not my fault, right? Because there can be a lot of shame wrapped up in having psychological distress. But this idea that the gender dysphoria is the underlying cause, and therefore the anxiety, depression, OCD, PTSD, ADHD, all of that will go away if you treat the gender dysphoria with permanent medical interventions. It's a really shaky assumption.
Okay. I'm going to give you my speculation on this. I can't prove this to you, but here's my speculation. If that guy's a surgeon, I cannot possibly imagine. I'm not a surgeon. I don't know what surgeons, I don't know enough about the kind of training surgeons go through, but I would be surprised, to say the least, if they did not have at least some classes, or it's been incorporated into their classes, to understand peer-reviewed literature, to understand methodologies, to understand, quantitative metrics, quality. I would be surprised. So the fact that he would make such a statement without an argument or evidence means to me, and maybe this is my lens, that he's making that statement because his moral mind is overriding his rational mind. Because I don't think he would do that with sugar and donuts, right? The causation with weight gain. Like, if he wouldn't do it with other things, then why is it in this very specific domain he does it? And my speculation is that his moral mind is overriding his rational mind. But you don't have to comment on that. I'm just throwing that out there. I think that's a cogent explanatory mechanism for the wide-scale systemic derangement that we're currently seeing. All right, Reed, keep going on the video.
How should we treat children who are possibly transgender? Well, research shows that children who are prepubertal, meaning ages 5 to about 12, and they identify as transgender, they know their gender as clearly as their peers who identify as cisgender.
I call total bullshit on that. I call unequivocal, categorical, total bullshit on that.
100%.
How on earth, this kind of study that you would have to design to state that with any confidence? You would, I mean, I could tell you, but it'd be, so you would have, okay, so I mean, truly, I mean, it's just, Schellenberger's right. It's just extra crazy. Like, why would anybody, what would lead one to even believe that in the first place?
So I did an episode of my podcast called The Myth of the Magical Child with Matt Osborne. And when he was 15, someone told him he was an indigo child. And we talked about the sort of psychological phenomenon of needing to believe in this sort of divinely inspired child, the wisdom of the child, because the child is closer to God, right? And so in our secular society, where so many of the people who believe in this stuff are not religious, here's this religious belief coming in to fill the void that children have this divinely inspired knowledge, that children truly know themselves.
Yeah,
but it doesn't pan out.
No, I mean, they're closer to God. What? They're closer to the ground too because of height. Does that make them a mollusk? Or, I mean, no. I mean, the whole thing is just totally insane. Okay, Reed, keep going.
And they benefit from the same level of social acceptance. Now, this means that these children didn't come across as confused about their gender identity, but as certain in their gender as cisgendered children.
Pause.
So,
I believe that. That I believe. And I believe that because there's a reinforcement mechanism So, and I also believe that because it's a kind of version of preference, a flavor of preference falsification, I believe that, but that doesn't make it true. Right. And it doesn't mean that it's, temporally non-contiguous with other self-proclaimed identities. So again, the idea that somebody who's young can claim to be certain about an identity that they have, maybe they're certain that they can, fly or that they have superpowers. That doesn't correspond. It doesn't have any necessary correspondence to objective reality.
Well, and what is certainty based on? Because most people as children don't spend a whole lot of time thinking about themselves. That's a beauty of childhood. That is the thing that is innocent and maybe arguably closer to God about childhood, is that it's not all about me and my ego and what I think about myself. Part of my criticism of gender identity ideology is that it encourages this narcissistic self-focus. Sexual orientation is about your interest in other people, which is healthy. We're social creatures, but this is all about me, me, me. So as a child, most kids don't go around thinking, I'm a boy, I'm a girl. Like, you're not thinking about it. But if someone were to ask a boy or a girl, how do you know that you're a boy or a girl in a society other than the one we're in right now, where they're being taught all kinds of nonsense about it? What would be the basis for that kid's certainty? It would be, well, frankly, it's because I have a penis, or it's because I have a vagina.
Why would you even ask someone like that? Like, why? What is it? There really is an obsession with this. This is super creepy, man. There really is an obsession with like sexuality and children's pride. I mean, it's creepy. It's creepy. All right, keep going, Reed.
So just as, let's say, a cisgendered boy naturally identifies as a boy, a transgender boy naturally identifies as a boy.
All right. So I'm telling you, I can only take so much of this. No, I mean, I talk about aliens and I don't get upset or anything, but when you start talking about this stuff, I mean, it is so obvious that this is a mass delusion. It is so obvious that it is so ghastly. Do you want to do more, or do you want to do some questions? I'll leave it to you to choose.
Oh, what is this here?
Do you want
facial feminization surgery or something?
You've answered the question. Let's hit play, Reed. Let's see what new form of derangement we have today.
Now, what about gender affirmation surgery regret? There are people who believe that a high percentage of transgender people who undergo gender affirmation surgery regret it later. Well, the truth is, a recent study revealed only a 1% incidence of surgery regret after gender affirmation surgery. Okay,
Colin Wright debunks that, but there's no name. See, why wouldn't you put the name of the study there? Why wouldn't you put the journal that it's from? Why wouldn't you put, so a person like me or someone who's curious and wants to look at the methodology, so let's look at the methods right here. The prevalence of regret among patients, 1% respect. A total of 77 patients regretted, 28 had minor and 34 had major regret. Well, how is that 1% unless 7,900. Okay, so that's a pretty big N. Okay, I don't want to spend the time analyzing the study, but okay, good. Let's let's see what else the good doctor has to tell us, or the doctor.
Just 1%. So the belief that a high percentage of transgender people who undergo gender affirmation procedures regret them later, that is just not true.
I'd be curious to see the timeline that they're looking at. I mean, given the permanence of these interventions and the ways that they foreshorten people's lifespans by increasing the risk of all kinds of illnesses that people don't care about when they're 15 or 25, but you start caring about when you're 40 and 50 and 60, the cardiac risks, for example, the risks of Alzheimer's and dementia. I mean, these kinds of things that you have to take into consideration with age. And given the permanence, I wouldn't trust anything that's asking people about regret after 6 months, a year, even 2 years. The studies we looked at in our film showed the highest levels of regret is 7 to 10 years. And given the exponential growth curve of how many young people have been pursuing this in the last decade, I just don't think we have enough data on the outcomes of the kids who've been transing in the last 5 to 10 years.
Yeah, and data collection would obviously be a problem. Data reporting would be a problem. creating stigmas around that. Many people who have detransitioned said that they have lost their friend community, et cetera. So there are issues that in order to deal with them in any scientific way, you would have to be, or methodologically rigorous way, you would have to be honest in the data collection methods. And clearly this is forwarding an agenda, and it's not scientific and it's not evidence-based. Okay, so you've mentioned a few times. Now I want to talk about your wonderful film, No Way Back, The Reality of Gender Affirming Care. And I'd like to read, can you please play the clip of that? I'd like to talk about this. Stephanie, please.
One night I remember having a dream that I was a boy. I felt so happy after waking up from that dream. It just felt like I was excited to be alive. And then I got up and went and looked in the mirror, and just that happiness was like crushed. Based on the information that I had, that medical transition is by far the best treatment and that you are at risk for suicide if you don't follow that path, I thought I only really had one path that I could take.
I became alarmed back in 2019 after I realized I was seeing more kids with gender dysphoria, and every single one I referred to the gender clinic was being transitioned.
So it's often said that puberty blockers are reversible, but the majority of children who are started on puberty blockers, over 95%, go on to take cross-sex hormones. Puberty blockers cannot be considered a standalone intervention.
If it worked, I'd be very open to it. It's like putting diesel in the petrol tank.
There was a study looking at the Swedish population of those who had transitioned that found that those who had transitioned had suicide rates 19 times higher than population-matched controls.
Puberty blockers followed by cross-sex hormones. The fact they're being offered outside of clinical trials, despite the fact there's so much unknown about long-term risk, is a scandal in and of itself.
It's up to us on the left to walk this back. I want liberals to make room for gender diversity, and that includes masculine girls and feminine boys, without telling them that they need to leave their sex category because they are different.
Like I said, I have to now live with what I've done. These doctors and therapists put me through this. They had no reason to, except for the fact that I said it.
Okay, so we just heard that guy give a study. What was interesting, by the way, in the trailer, did you notice that it showed that the where the study was from? Okay, so we just heard Dr. Yuan or whatever, I don't know how to pronounce his name, but claim 1%. Now you're claiming, and we've seen these procedures reversed in Scandinavia. How does one figure out which is true? Like, is the claim, and just accept by fiat that the doctor actually had the study in there and looked reasonable? Like, how would one figure out which data set to believe? Like, let's say someone's trying to figure this out, and here's this guy saying, well, hey man, it's like 1%. It's like 1%, 1 out of 100. And then we have the film and other people arguing on the other side, like, hey, we have this data set. How does someone know what data set they should believe?
I mean, I think you're more the expert on that than I am. I mean, we both know how to read these articles and kind of look at the methods. And like you were saying, like how long the study is looking at, what information it includes, what information it excludes, the confidence intervals, all that kind of stuff. But I think, even if it was as little as 1%, which we really don't know that, and I've seen studies indicating otherwise, that the way that 1% is dismissed is really scary. And the experience of detransitioners it's overwhelming. But then there's the precautionary principle, right? So all of this is based on saying that their idea is that a 1% rate of regret is so minimal that it's good because the other 99% were saving their lives. That's how the logic goes, right? And that's sort of the stuff that I want to challenge, because there is a powerful role of belief here. And we've allowed ourselves to create this culture that is telling young people that this is the explanation for why you're distressed, and that these are the treatment options that are going to make you feel better. And telling that to a vulnerable young person, of course, is going to cause them to fixate on it, and in many cases, to actually believe that if they don't receive the treatments that they want, that they will be suicidal.
Okay, so when you say the precautionary principle, you mean that you should err on the side that it's intrinsically dangerous or inherently dangerous until proven otherwise, like
Sure, let me break down what I meant. So
yeah, please.
let's take the assumption that it's a 1% regret right now. I don't believe that, and I've seen evidence to the contrary. And I think we have a lot more detransitioners heading down the pipeline. But even if that were true, even if that was the best information that we had, the precautionary principle would say, well, if 1% of people who do thing X end up living with terrible pain and worsened suicidal distress and, bladder dysfunction, bowel dysfunction, sexual dysfunction, disability, right? Not knowing how to move through the world and all the mood and mental health implications of what cross-sex hormones do to the brain. If 1% of people have that bad of a reaction, the precautionary principle would say maybe we should take that 1% reaction seriously, right? But I think the reason that that's not sort of how the current public narrative about it goes is all resting on the assumption that these magical trans people who magically know who they are at heightened risk of suicide if you don't affirm them, right? So it's the idea that you're saving lives,
right,
that makes them say we should go through and save the 99% even if the 1% is risked. But that's where I would challenge the narratives that we're telling as a culture about suicide, about resilience, about the nature of a young person's distress and what they can do about it.
Okay, in all fairness, I think so. If you do want to invoke a precautionary principle, and I don't know what the calculus would actually be, but let's say that the scale went from -100 to +100, and let's just, I'm just, this just went.
Oh, Peter Boghossian's doing that Peter Boghossian thing.
Yeah, no,
Scaling.
this is not going to be that kind of scale. This is going to be more of a calculus scale. So in terms of figuring out on a maybe utilitarian calculus. So let's say that 1% of the people, let's say they receive maximum negativity from it of -100. But then the claim is that you have the other 99% of the people, or 99 people if it's 100, if the n is 100, that you have, they go from +1 to 100. So if you just added it up that way, and again, I don't know if that's necessarily, I'm just thinking about a heuristic, but I don't think that the precautionary principle is operative there. But I don't know if you want to comment on that. I guess the other thing that I was thinking is that at what percent would you say of no regrets? Because they'll just say, well, they're it's the no true Scotsman. Well, they weren't really trans. They I don't know. At what percent? At what percent? Like
I wouldn't
0,
give a percent.
Well, if it's 0, like if we know and we have honest people, and it's not 0, but just accept by fiat that this is true, that nobody regrets this. Like everybody's like gung ho between 1 being minimal happiness and 100 being over the moon happy. Like la la la, I'm this is the best thing I ever did. If 0% of the people, if literally nobody regretted it, would this be a problem?
So I want to separate out regret, which is a psychological state,
okay,
from physical consequences.
Okay.
Right? So I'm coming at this from the standpoint of sort of drawing distinctions and boundaries between my field, psychology, and the medical field. And I have a problem with my field being co-opted into encouraging people to do something medical that has harmful consequences. So if we're talking about regret, that's subjective, right? And, I think I glanced briefly at some of the comments. I know there's like hundreds of comments, so I can't read them all, but I glanced, and somebody said something about how like Jazz Jennings isn't like openly regretting.
Oh yeah.
Right. And same thing with that kid who was on National Geographic, like Avery or whatever,
Oh,
like some
yeah,
things Avery has been saying. There are a lot of people who may not ever consciously connect with a feeling of regret. And I would say from a psychological perspective that it might be too overwhelming. They might be well kind of guarded or defended against that overwhelming emotion. But if we look at complications, if we look at medical consequences, that is something more easily quantifiable. And that's what we talk about in our film. We talk about the medical reality of the surgical complications, the pain, disability,
Sure.
infertility, increased risk of heart attack, stroke,
And you
cancer,
can't have
right?
orgasm. Is that correct?
Right. So if puberty blockers are administered according to the plan that Dr. Winn or whatever said at Tanner stage 2, what's her name? His name, the trans surgeon Erica Anderson.
Oh yeah.
Erica Anderson admitted, right? Erica Anderson, who has given puberty blockers to kids, admitted that these kids will never be able to have an orgasm. So even if a kid is on puberty blockers and they grow up saying, I'm such a happy trans kid, I've never had an orgasm, I never will, but I'm just so happy in my joyful gender identity. Like if they're saying that,
That's an excellent point.
but
Right.
they're not, they're not able to have sex, they're not able to reproduce. Like,
Okay. So let's talk about that, because I think that you've just answered that objection. In order to say that, so I'll give you an example. I'm deaf in my left ear, and I can tell you it's a pain in everybody's ass. It's a pain in Reed's ass. I got to always move to one side. I always sit one side of the table. It's a huge pain in the ass. And I don't know if you knew this, a little far afield, but there's a bunch of people who are, if that's why I don't go swimming, because if I go swimming and I get water in the other ear, that's it. It's over for me. I can't hear anything. It's terrible feeling. And I got tinnitus in my ear. But anyway, there are a non-trivial number of people in the quote unquote deaf community. I don't even know what people mean by that, but people who are deaf thinking that you shouldn't cure deafness because it's a good thing. It builds community. And I don't know what other, but the reason that I can say that that's bullshit is because I once had hearing, right? So and I can tell you it sucks. I don't know where things come from, the sounds. So I think that if you apply by analogy that example to, I'm trying to think of a polite way to say it. I just can't think of any polite way to say it. But if you've never had an orgasm, then you're not really situated in a place to even place yourself on the scale. Like you would need to have been in a position where you were sexually active, where you have had orgasms, and then you transitioned, and then you no longer have that ability. And if as a consequence of that, you said, oh yeah, now I'm happy, this is the right thing for me, that would carry more weight in the calculus. Like the gravitas of the testimony, everyone's, into testimonies, the gravitas of that testimony, the legitimacy of that testimony would weigh more than someone who's never had those experiences in the first place.
absolutely. Thank you for saying that. And I want to add to that detransition is one of the worst things a person can go through. And I mean no disrespect to any detransitioners. I actually mean this coming from a place of sympathy. And if it wasn't the worst thing for you, then I am celebrating that. But I just honestly, from listening to so many of them, detransition is rough. It is so rough, right? The breakdown in your whole worldview, your sense of yourself and everything you believed, and then dealing with not being able to find doctors who know what the hell is going on in your body, and feeling like you're 22, but you have the body of a 50-year-old because these chemicals messed you up.
Hey, watch it now. I'm 57 this month.
It is rough. I just mean detransition is so hard. And again, I mean no disrespect to any detransitioners. I wish you the best. I hope it's not hard for you. I support your strength and resilience. But my point is that people who have taken steps down this path have a lot of reasons to be psychologically defended and guarded against facing the possibility that they might have made a mistake, which is why I think regret isn't necessarily the best measurement, because I've seen as a therapist, sometimes it takes years for some of my clients to get in touch with a certain emotion. Like thinking about people who have repressed anger, people who are people pleasers, who are terrified of their own anger. I mean, I've actually had clients where I keep track of how many minutes into the session they let on to their anger. And at the beginning of therapy, they're like, they will never let their anger show. And after 3 months, 45 minutes into the session, they'll let their anger show. And after 8 months of therapy, 20 minutes into the session, they'll let their anger show. And then you discover they have all this repressed anger, right? So as somebody who's used to dealing with repressed emotions, taking time to come up and needing to help people create the right situations in their life to deal with repressed emotions that they're guarded against, of course we protect ourselves from overwhelm. So I mean, there are trans people who are promoting this very harmful slogan, death before detransition, which just shows you, like, I mean, that's a really harmful narrative, because I want to instill hope in anyone who's considering detransitioning that you can survive it. Like, you do not need to go down that way. But there's a lot of guardedness against facing the reality that they might have made such a life-altering mistake at such a young age, and that they might have been betrayed and misled by the adults that were supposed to protect and guide them.
Wow, there's so much there. That sentiment is lovely. I know that I've kept you for a long time, but do you just have a few more minutes? Is that
Sure.
okay?
Yeah, I'm good.
Okay. All right. Thanks. I appreciate that. And if you need to jump, let me know, because I have a bunch of other questions that I've written out, and then we want to take some questions for you. So last year you were accused of practicing conversion therapy, and I've always heard that in another context. So what is conversion therapy?
Wait, you've heard my story in another context?
Oh, didn't somebody accused you of being, what was it?
Yeah. I don't know. Did you see my interview with Helen Joyce, or I just don't know? How much
No,
you know.
I interviewed Helen Joyce. So what is so you were attacked for the conversion therapy thing, yes?
Yeah, so it was a combination of trans rights activists who piled on me on Twitter and told me they were going to report me to my board, and I got ahead of it and I contacted the board. I was like, you are going to be hearing from these people, and here's what I have to say. People accusing me of conversion therapy simply for being somebody who is a therapist that has gender critical views. And then separately there was, and I will speak very little of this, but there was a parent who attended one session of the support group that I ran for parents, had a completely different experience than any other parents in that group, and went on a pretty massive smear campaign after that, including a board report. So, and took a lot of things I said completely out of context and twisted my words around. That every therapist worries that every now and then you can just encounter one of those people in your practice who might be the sort of person to do something like that if they're upset with you for whatever reason. But the long and short of it was that there were basically these kind of two allegations, but that they all kind of came down to my gender critical views. And long story short, I successfully defended myself against it. I have no actual marks on my record, but it did give me a good scare and caused me to stop working with adolescents. So now I only work with parents and detransitioners when it comes to the gender issue. So I told the whole story to Helen Joyce. It's episode 11 of my podcast. It's my most watched video on YouTube and the most listened to episode of my podcast. So it's called Debunking the Myth of Conversion Therapy, and that's where I break down what happened to me.
Yeah, thanks. I appreciate that. I'm just going to ask a couple more questions real quick. So one of the things that I read was that you've noted the conflation of gender identity and gay identities.
Yeah.
So can you please explain that to people? Like, what's the difference and what do you mean?
Well, so the whole LGBTQIA, right? Like lumping together this whole community. And as far as the I part, intersex means people with disorders of sexual development. I've talked to DSD activists who do not appreciate being lumped in because of the basis of their medical condition. But in my view, they're diametrically opposed. And I've spoken with a lot of gay and lesbian people who feel this way as well. And part of how I think about it from a psychological perspective is that sexual orientation is fundamentally about your interest in other people. And interest in other people is a healthy thing because we're social creatures. Now, that doesn't mean everyone is functioning healthily in relationships, but if you strip it down to the bare bones, like the essence of being interested in other people is a good thing. And it's a driver that can compel healthy motivation to find healthier ways of connecting, right? But gender identity is an inversion of that instinct towards the self. And I think this is a reason that there is a high comorbidity rate between autogynephilic transsexual males and narcissistic personality disorder, for example, right? Because
that's what you did to read. I like that. Mm-hmm. What do you mean by inversion? And could you please define autogynephilic for people? I'm actually reading a book on that now.
Right. So, so there's an inversion of the instinct, and it makes me think of, so in Gestalt therapy, are you familiar with the Gestalt
Yes.
awareness cycle? Right. So, so there's the awareness cycle and its interruptions, right? So to fulfill any need, we start with sensation, then we become aware of that sensation, then we start to scan our environment for how I can respond to that sensation, then we start to mobilize towards action, eventually we make contact, we satisfy that need, and we withdraw and move on. So for example, sensation of hunger, then you become aware you're hungry, then you think, what can I make to eat? Then you get some food together, you eat it, and then you're not hungry anymore. Happens thousands of times a day in various ways, right? So, but at every stage of that cycle, there can be an interruption. And so various like dysfunctions and defense mechanisms correspond to that dysfunction. So, so for example, someone who has a blockage in the scanning phase might be somebody who either doesn't take action to meet their needs, or maybe they jump towards always meeting their needs in a certain way rather than having a broader range of options. So,
yeah, where are you going with this? Because yeah.
Sorry, I my mind.
No. It was important to sketch it out so now people have a better understanding of it. Okay.
So any healthy movement toward fulfilling a need can become like inverted or deflected or like turned away in some way that leads to some kind of dysfunction, right? So the healthy instinct when it comes to the emergence of sexuality in adolescence is to become more interested in other people, right? And how that can become a driver of behavior is that, let's say you're kind of like an average looking guy, you're certainly not a football player, you want girls' attention, and you're 14 and really horny. Well, what do? You learn to tell jokes and play the guitar, and that's how you start getting girls' attentions, right? But the inversion here is that rather than becoming interested in other people, how can I make myself more attractive to potential partners? How can I learn to flirt? How can I become charismatic, right? Instead of that, it's me, my gender identity, right? And if you think about the autogynephilic, so to define that, a man who is sexually aroused by the thought of himself as a woman. So an autogynephilic male, a man who, let's say, wants to have breasts and who's also attracted to women. Now, that's not something a woman's going to be attracted to. The average woman doesn't want a man with breasts, right? So it's an inversion of the instinct to how can I be appealing to her so that I can connect with her sexually and romantically. Instead, it's how can I have this for myself? How can the entire sexual instinct be directed at myself so I have full control and am fully self-absorbed? And then I'm not interested in other people. I'm not interested in making myself more attractive or appealing to other people or knowing how they feel.
Okay, I would love to have this conversation with you because I'm reading a book about this right now, but it's 5:37 and I wanna ask one more question. We have a lot of people who want to ask questions. Last question, and then I'm gonna take general questions. Other countries are backing away from gender hormone treatments and surgeries for young people. We talked about the Scandinavia thing. What do you think it will take for our country to follow suit? Do you feel what is it going to take?
My hope would be class action lawsuits. I know we have some individual lawsuits right now. None have been won yet, but they're all in progress. So we have Chloe Cole, Layla Jane, Camille Kiefel. That's at least 3 Detrans lawsuits I know of in the US. I know more cases are coming down the pipeline, but I'd really like to see class action lawsuits.
Yeah, Chloe's interview with Peterson was quite interesting, and she has an interesting Twitter feed as well. Okay, cool. So thanks for that. If you have just a few more minutes, I am sorry I kept you over. No Reed, let's take some Emerald tier, $5. Thank you. All this goes to my nonprofit, National Progress Alliance. I am convinced plastic surgeons are charlatans who are incentivized to make people unhappy with their physical appearance. Not sure. Oh, you mean like, does Emerald tier mean like gender surgery? I don't.
Well, I will comment. I actually just interviewed, so coming out July 31st, I believe, on my podcast is an interview with Jessica Pinn. Are you familiar with who she is?
The name of your podcast is?
You Must Be Some Kind of Therapist.
And it's available?
Anywhere podcasts are found: YouTube, Apple, Spotify.
Thank you.
Sometherapist.com. So I have an interview coming out July 31st with Jessica Pinn. She's an activist to bring awareness to women's sexual anatomy because she was harmed by a labiaplasty at the age of 18. So she was basically given misleading information that her perfectly normal labia minora were hypertrophic because that was the current trend. And at age 18, she was misled into thinking that it was a form of self-care to get basically her genitals trimmed down. And in the process, her clitoris was harmed and she lost sensation permanently. And so she's done really amazing work bringing awareness to this issue. She's gotten 12 medical textbooks changed. She's basically been educating doctors to make sure that they actually understand female genital anatomy. So, and that's sort of a follow-up to my interview with Simon Esler, who created the documentary Cut, Daughters of the West. With regard to the comment on plastic surgeons, absolutely, there is a market for that. If you watch Simon's documentary, you'll see that the plastic surgery industry developed around World War II to help victims of war whose faces were mangled and who had serious bodily injuries. But then there was this whole industry, and then they had to find new customers, and it's just grown ever since.
That's good. I didn't know. As it relates to the question, I didn't know. Okay, Reed, do we have another one? Maverick Christian, $5. Hey, Peter, I read your manual for creating, but years ago it didn't convert me, but I appreciate the effort. Okay, cool. Thanks. Well, what the purpose wasn't to convert you. The purpose was to make you more aware of why you believe what you believe, to give you more rigorous epistemology. All right, Reed, do we have any more? I think we have some more. It is possible to Mars. Hey, Mars, how's it going? Mars, have you gotten your black belt in jiu-jitsu yet? Stephanie, do you do jiu-jitsu?
Me? What?
No. Okay, I take it to no. Is it possible to want the wrong things? Sam Harris. I think Peter just clarified part of Sam's moral landscape that I didn't understand. All right, cool, great. I used to teach that book. It's a wonderful teaching book. It gets people who would otherwise be disaffected or uninterested really found that book engaging. All right, do we have any more, Reed? Are we good? We're good. We're all good. All right, cool. Let me just say where you can be found here. No Way Back, the reality of gender affirming care. We talked about your private practice, and we'll post this in the YouTube. Your interview with Helen Joyce that you talked about. And then you're on Twitter. What's your Twitter handle?
Some Therapist.
All right, cool. Did I miss anything, or is there anything that I should say where they can find you?
I'll just run through. So No Way Back, you can watch at nowaybackfilm.com. It's available to purchase to stream now, or you can pre-order a DVD. And then I'm at sometherapist.com. Some Therapist is my handle everywhere.
All right, cool. And is there any, I always, when I do the street epistemology with Reed, I always ask people this question. Was there anything that I didn't ask you that I should have asked you, or that it's like, were there any gaps in the questions? Because there was just so much stuff. But should I have asked you something?
You know what? I'm just relieved that you didn't ask me for advice for parents, because that is what everybody asks me. And it's what I make a living doing. Like I provide, counseling and consulting services to parents who are worried about their kids. And every situation is unique and different. So I can't think of anything that I wish you'd asked me.
If people, and you've said where they can find you, so if parents have questions or they're going through this and they're experiencing this and they're just probably bewildered, frankly, like
there's a contact form on my website. So long story short, if you're in Oregon, I do have, a small counseling practice here. My next openings are probably in September. But I do consulting and coaching as well. That's for people in, wherever, if you want to just spend an hour talking with me, picking my brain about whatever. And it's not officially therapy. I do that. And then you can also email me and ask if I know a therapist in your state. So I do keep a referral list of all the therapists from around the country, sometimes around the world, who reach out to me saying that they share my concerns. And so I don't have a referral in every single state, and not all the referrals are willing to work with questioning youth, because depending on the laws in their state, they could be at risk of what I went through last year. But I might be able to find someone for you.
Okay, cool. Hey, so don't hang up yet, or whatever it's called, click leave. Reed's got to do something with it. Hey, thanks everybody for listening. Thanks, Stephanie. I appreciate it. And I hope that this conversation made you think and helped you clarify some issues.
Thanks for having me, Peter.
Right on.